Okay, so today we're going to talk about the neuro system, specifically strokes, whether it be TIA, an ischemic stroke, hemorrhagic stroke, different signs and symptoms of that, patient care interventions for it, things like aneurysms, different types of surgical interventions for it, different drugs you would take for patients with stroke, different things like that. So let's go ahead and get started. First, we'll talk about transient ischemic attack, or TIA. Basically, what a TIA is, just a mini stroke. It's kind of a warning sign to let you know that maybe you should get checked out, because if you're having TIAs, then you're likely to have like a full-blown stroke. The difference with the TIA is that the signs and symptoms typically last less than 24 hours. So the symptoms that you have will be similar to a full-blown stroke, but they won't be permanent. They'll come and go. They'll be transient, hence TIA. And what this is a result from is a change in normal blood supply to the brain. So whether this be from like a vasospasm or temporary blockage or whatever, what have you, a lack of blood flow to the brain causes a TIA. Looks like a stroke, same signs and symptoms, but they go away within 24 hours. Now, full-blown stroke, there's two different types. And this is where it's not transient, that the signs and symptoms last. And if it's permanent damage without intervention fast enough, these signs and symptoms I guess I should say the damages of the stroke will be permanent. So there's ischemic, I hope you can read that. And then there's hemorrhagic. So ischemic has to do with there being a blockage, and hemorrhagic has to do with like bleeding out. So within ischemic, there can be two different types. There can be, well, not two different types, it can be from different causes, I should say. It can be from a buildup of plaque, like atherosclerosis. So we can put plaque here, / atherosclerosis, which is a hardening of the arteries. When something is sclerosed, it's hardened. So this is like, if you have, most of this is from diet. Like if you have a diet too high in fats, cholesterol, that sort of thing, you get, the buildup of plaque in the arteries. And that basically narrows, this is a cross section of an artery, and you have plaque that's building up, all here. And now you have like this tiny restricted area for the blood to flow through. That decreases the blood supply to the brain. Now this is going to be a much slower process, the buildup of plaque and atherosclerosis. You don't build up a complete blockage of plaque overnight and have a stroke the next day, right? So it's kind of a slow buildup, and this is one we might see like TIAs, and you go get checked out and you realize, oh, you have a bunch of blockages, you need to go in and get a surgery scheduled to get the plaque removed, right? The other type of ischemic stroke is an embolus or a clot. An embolus or clot. So both of these are blocking the artery. So right, the first one, it's blocked with plaque buildup. The other one, it's like it gets blocked with a clot blocking the area, right? So, this can be a DVT. People with like AFib, atrial fibrillation, are more susceptible to getting clots. So this one is going to be a lot faster, right? This is going to be more rapid onset. So this one's going to be fast. This one's going to be slow because, you can throw a clot, anytime, really. Obviously, you have different risk factors, not, for being susceptible to having a clot. Like I said, AFib is one of them, being a smoker is another one, things like that. So yeah, faster, slower, those are the two types. Ischemic, just meaning blocking the blood supply, which reduces the oxygen and all of that. Now, hemorrhagic, there's several different ways that you get hemorrhagic. Hemorrhagic comes from like hemorrhaging, which is like bleeding out, rapid blood loss. So it can be caused by several different things. The first one is you could have an AVM, which is an arteriovenous malformation. And I talked about this more in a previous video, but also under the neuro category, under the traumatic brain injuries, one where I talked about like head traumas. So I talked about AVMs, but basically it stands for arteriovenous malformation, and it's just where the arteries meet the veins, there's kind of like this weird like jumbling of the vessels, and they don't flow properly, and so they're susceptible and liable to rupture because they're just fragile and they're not formed properly. Another one is an SAH, subarachnoid hemorrhage, and this is a brain bleed. And again, I talked more about these in particular, more in detail in that video, and I'll put it in the comments if you want to see it. This is basically, you have the different, let's say this is your brain, looks like a cloud, I know. You have different layers surrounding your brain called meninges. You've got your pia mater, dura mater, things like that, pia, arachnoid, dura mater. And so a subarachnoid hemorrhage is, there's under the arachnoid meninge, you'll get like a bleed right here, if that's the arachnoid layer. And so it means under, subarachnoid, and it causes a brain bleed. And the problem with this is that as blood is coming to the area, it's taking up space in the skull, which is a problem because your skull doesn't expand, right? If you're throwing all this blood in there, it's going to cause damage to the brain, increase the pressure. We talked more about intracranial pressure in that other video I was referencing. An aneurysm. So an aneurysm, there's a couple types, and we can talk more about that when we get to surgical intervention. But basically what happens with an aneurysm is that the blood vessel, like let's say this is an artery, it gets weakened somehow, like the vessel wall gets weakened, and basically leads to rupture. So then all the blood comes out. And there's a few different classifications of aneurysm, and we'll get to that a little bit later. And then another cause behind hemorrhagic could be severe hypertension. So like someone just has blood pressure so high that it causes them to have a stroke, right? Like just bursts the vessel because the blood pressure is so high. So it's kind of similar to an aneurysm, where like it causes the vessel to rupture. Hypertension doesn't always cause an aneurysm. So let's see if you can see that on the screen. Okay, so again, this has to do with bleeding. This has to do with blocking blood flow and reducing oxygen getting there, because we know the red blood cells carry oxygen. Okay, so let's talk about some risk factors that make you more susceptible to developing a stroke. And I'm going to use a different color. Let's use blue. So risk factors are basically things that make you more likely to have a stroke. Some are modifiable, some are not. Modifiable means that you can do something about it to prevent it. Other things you can't. Like, for example, like being African American, for example, you can't modify that. Like I can't, like if I was African American, I can't make myself not African American. That's just part of my DNA. So that's a not modifiable risk factor. Whereas something like smoking is modifiable because I can choose to not smoke. Like I can stop, right? So some risk factors, actually, like I said, are being African American makes you more likely to have a stroke, and that's just something about the genetics. And statistically, more African Americans have them. What else? Being male puts you more at risk of having a stroke. And sometimes it's unclear whether some of these are like nature, like by nature, the genetics are, or it's kind of like the lifestyle that typically men typically have, a diet heavier in meats and like fatty foods, whereas women typically don't as much. So I don't know, we don't always know if like the risk factors are just because males somehow genetically or just based on the typical lifestyle. But anyways, African American males especially, having hypertension is a risk factor, and this can be modifiable if the hypertension is due to lifestyle or like diet. But sometimes people just have genetically high blood pressure and they're not doing anything wrong. Another one is type 2 diabetes. I'm going to put 2DM for diabetes mellitus. And type 2 diabetes is pretty much always due to lifestyle. So that is modifiable if you prevent yourself from developing type 2 diabetes. Basically, type 2 diabetes is pretty much a risk factor for everything. So if that's on NCLEX, it's probably the answer. So type 2 diabetes literally is a risk factor for pretty much every problem. That's a freebie. AFib. Okay, why is AFib a risk factor for stroke? Well, like you said, AFib makes you more susceptible to having clots, right? Because like the heart is pumping, and normally we like to have a nice strong heartbeat, right? Where it pumps out all of the blood, in a nice smooth motion. Whereas with AFib, atrial fibrillation, the atria isn't fully contracting, it's kind of just quivering. And so it's not really sending out strong beats with the blood coming out. So the blood that's inside of the atrium, inside of the little, the chambers, starts to coagulate and start clotting up. It's kind of like with stagnant water, like on a lake, you get like a kind of a gross film that kind of starts to develop on top of the water, whereas like in a rushing river, you don't have that, right? So it's kind of like the stagnant lack of movement that creates that film, kind of the same thing with AFib. So people usually are on medications if they have AFib to prevent themselves from throwing a clot, having a ischemic stroke. Another one, another risk factor is previous heart attack. Same kind of reason, your heart's just not doing what it's supposed to. Another one is prosthetic valves. So they're for some reason, having prosthetic valves puts you more at risk, like AFib, of throwing a clot. Something about the prosthesis inside the heart and the blood passing through it often causes it to form clots. So usually people that are on have prosthetic valves or on some type of anticoagulant. Here's some more, let's go over here. Some more modifiable risk factors are like if you're a smoker. Reason being is that when you smoke, it's a strong vasoconstrictor, which again leads to hypertension, which is one of the possible reasons for hemorrhagic stroke. But also the smoking tends to contribute to atherosclerosis, hardening of the arteries, especially in the lungs. So smoker, diet's a big one. If you have a high diet, cholesterol and fat, that contributes to plaque buildup over here. Sedentary lifestyle. Obviously, not getting good exercise is going to weaken your heart, also weaken your vessels, make them not as stretchy, and lead to the the hardening. So these are kind of all modifiable, like you can do something about these. Increased age, obviously, well, no one can really help getting older. It just happens. And then the last one is family history. So this is one of those things where like sometimes you just inherit things, like for example, cancer runs in my family. Hopefully I can have a good lifestyle, have a good diet, and try to avoid a lot of that, but some of it's just genetic no matter what you do. So anyways, so these are the risk factors that contribute to someone developing a stroke. So next we'll talk about some diagnostics that you can do to kind of rule out and confirm whether or not someone's having a stroke. I'm going to go ahead and erase. I'm going to erase some of these things. I'm going to erase the risk factors and leave those up for now. I might need to reference it. Yeah, I'm going to use blue again. That was a good color. Okay, so some diagnostics that you can use to confirm someone's having a stroke. The big one is a CT scan. Now, the big thing is that you're going to want to have it without contrast. I know that when you get a CT scan, you can have it with or without contrast. And sometimes having it with contrast is really helpful. Now, with the case of a stroke, let's say someone comes in with signs and symptoms of a stroke, and just by looking at them, you don't know if they're having ischemic or hemorrhagic, right? All you know is that you're seeing signs and symptoms, which we'll talk about next, right after this, of like, oh, hey, they're having a stroke, like they're having the facial droop and the unilateral like neglect, whatever. It's like, maybe they're having a stroke. You can't tell by looking at them if it's hemorrhagic or ischemic, right? So if you were to use contrast, that would be difficult because let's say that they do have a hemorrhagic stroke. So they have, like, let's say this is the brain, right? And the point of the CT is to see, number one, do they have a stroke? And number two, if so, where is it, right? So because they might need to do surgery and either remove the clot if it's ischemic to get it out to restore the blood flow, or if it's hemorrhagic to quickly repair that vessel and stop the bleeding, right? So they need to know where in the brain it is, and that's what the CT will tell you. Now let's say, this is going to be super inaccurate, but let's say this is a blood vessel in your brain and it's hemorrhagic. So for whatever reason, it bursted open, right? And so you got all this blood in the brain, right? If you use contrast, the contrast is kind of like a dye that goes into the bloodstream. And so if there's all this contrast inside of the vessel and it ruptures, now the contrast is going to be all out spilled into the brain where the blood is. And then when you look at the imaging, it's going to look like this big like mess of like contrast dye. And you're not going to know where the stroke is happening or where the rupture is, because you'll just see a big mess of like dye and you won't be able to pinpoint, be like, the stroke is right there, right? Does that make sense? Whereas if you don't use contrast, you won't have that problem. You'll be able to like, oh, okay, I see the spot right here where the rupture is, or I see the spot right here where the plaque or the clot is, or whatever it is, right? So you don't want to use contrast if there's if you don't know which one it is, because you won't be able to see and find out where exactly the location of either the rupture or the clot is. So that's a big one. That'll probably definitely be on a test. CT without contrast. Something else you might want to do is a blood sugar check. And why? Well, a lot of the signs and symptoms that we'll talk about after this can mimic like hypoglycemia, right? So like a lot of like the confusion or the slurred speech, or like kind of that kind of stuff. You can be like, oh, they're having a stroke, but then you check their blood sugar and it's like, oh, their blood sugar is 12. Okay, that makes sense, right? So this just kind of rules out like something else that could be going on, not necessarily a stroke, because certain different things, can mimic other things. So like this is just a good rule out to be like, okay, especially if they're diabetic. All right, we said one of the risk factors was diabetes. So if someone's a diabetic and they're having stroke-like symptoms, they could be having a stroke, or their blood sugar could be like 12. So definitely want to do one of those just to make sure. Another one is an EKG. You'd want to do that just because you can see if they're having AFib. They might not have even known they have AFib, and you can see, okay, they're in a case of AFib right now. They're probably throwing clots. Just kind of rule out any cardiac cause, whether they're having an NI or whatever it is. So an EKG might be helpful, but the big one is the CT, right? To be able to see, okay, where in the brain is it, and is it hemorrhagic or ischemia? So, okay, we'll go ahead and erase this now, and then we'll talk about signs and symptoms. And I'm going to try a different marker because that one felt like it was dying. Let's try green. See if this one's any better. Okay, some signs and symptoms. There we go. That's better, I think. Okay, some signs and symptoms of stroke. And this will be, so this is kind of like, you can have these signs and symptoms with TIA, but they'll go away, right? You can have these symptoms with ischemic. If they are permanent, you also can have them, post-stroke. So like the signs and symptoms aren't just during when the stroke is actively happening, but like they will remain if the area of the brain is permanently damaged, right? There is hope of restoring some of the brain tissue. So like, let's say this is the brain, right? Let's say there's a clot right here. And so this is the area what we would call of infarct, right? It's not just for heart myocardial infarction, but we have an infarct to the brain, basically anywhere there's a clot or lack of blood flow. The area surrounding it, which is also getting damaged because it's like peripheral to the lack of oxygen. This area kind of surrounding it is called the penumbra. And this is the area that can be potentially salvageable if there's an intervention quick enough to save that area. But if not, the whole area surrounding it will also, get necrotic and die, and then you'll have more permanent side effects. So anyways, back to this. Signs and symptoms of stroke. Now, a lot of these are going to be usually unilateral, meaning on one side. So I'm going to put that here. Usually, not always, usually unilateral. And the reason for that is, you have the two hemispheres of your brain, right? You got the left side and the right side. So whichever side you're having the stroke on, if I'm having a clot on my right hemisphere, it's gonna cross to the other side. So that's gonna affect my left side of my body. So if I'm having a facial droop on my left side and having like arm weakness and arm drop on my left side, that's a right hemisphere stroke. And the opposite is true. If I'm having a clot on my left hemisphere, you're going to see the side effects on my right side. So it crosses. So you can kind of quickly tell like which side of the brain is being affected. Okay, so enough talk. Arm weakness, like I said, like the arm drop, like someone might be holding a cereal bowl, all of a sudden drop it. Dizziness, loss of balance. Slurred speech is a big one. They suddenly are just like slurring their words or unable to speak. So slurred speech. Blurred vision. Their eyes go blurry. And a lot of the symptoms you're going to see are like they're in the face, right? Because, well, I mean, the brain is right in the head. And so a lot of those symptoms are going to be like located in this region. So blurred vision or double vision. So you're like seeing double. And this is called diplopia. That's the scientific or the nursing term for double vision is diplopia. Okay, what else? Facial droop. I think that one most people are aware of. That's pretty common, like even outside the medical field. Like you kind of see like the corner of the mouth kind of turned down, like with a smile on one side and the other side not. Another fun term is hemiplegia. Hemiplegia, and that's Hemiplegia. Hemiplegia is basically the paralysis. So, I can't squeeze that in here. So, the paralysis that we're talking about, like you can't, move that arm or you can't move that side of the face. The hemiplegia means the paralysis on the one side, like hemisphere, hemi, like on one side. Hemiparesis, on the other hand, so not plegia, but hemiparesis just means weakness on the one side. So some people with stroke, they aren't completely paralyzed, like they'll still be able to move their left arm, but just like very little, just be very weak. So I'm just gonna put weakness there. See if I can move this over a little bit. Some more signs and symptoms. Hey, sorry, can I listen? Yeah, come on in. Another one is apraxia. Ooh. Let's pause this for a second. Okay, so another sign and symptom of stroke. You're probably familiar with a lot of these. Facial droop. Pretty much everyone knows about that one. Like smile on one side and you can't on the other side. Apraxia is a nursing term, which has to do with the inability to perform certain movements or gestures, but you actually have the ability to do it, but you just can't do it for whatever reason. So like a specific skill, like brushing your hair or brushing your teeth, like even if your arm doesn't have any specific problems, like you have no paralysis or no weakness, like your brain just like somehow forgot how to brush your hair. Like it's not that your arm is weak or paralyzed, you just like your brain's like, we don't remember how to brush our teeth. Because like that's something that you have to, it's a learned action. Yeah. Right. So it's kind of weird because you're like, oh, there's no reason why they shouldn't be able to brush their hair or tie their shoes, but their brain just like forgot. So that's kind of a weird one. So that's apraxia. So it's the inability to do actions. I don't know how else to define that. But that makes sense. Yeah. It's kind of weird because like there's different pathways in the brain that like you don't think about it. Like when you're riding a bike, you don't actually think about like, okay, I'm gonna like move this one leg while I move this leg and make sure to keep the balance. You just kind of like subconsciously do it. So it's like certain things like that are subconscious like movements, like your brain just like forgets with the stroke.
There's no reason.
It's just whatever part of the brain that was damaged. Okay. Just can't remember how to do it. Yeah. So it's like very specific actions, like skills, like I mentioned, like that. Another nursing term is agnosia. Agnosia, and you'll notice that they like all start with A, which is like the absence of, like the inability, like abnormal versus normal. So like agnosia, apraxia, they can't do it. So agnosia is the inability to recognize familiar objects. So this one is similar to this one. This one's having to do with inability to do certain actions, and this one's the inability to recognize objects. So it might be hard to tell at first what the difference is. Like again, someone might not recognize a brush. Like, what is this? Like, I don't know what this is, but it's like you should know what that is because you use it every day. So you might not know necessarily if it's that they don't recognize the object or if they've forgotten how to do it. Does that make sense?
Yeah.
But you could tell after someone like, hey, this is a brush, you brush your hair with it, you show them. And if they're able to do it, it would be like agnosia, versus if they like for some reason can't, it'd be like apraxia. Does that make sense? So
they can have both.
You could, you know, I don't think they go into this that deep in your class, but like certain halves of the brain, different spots are more likely to have certain ones, like this area versus this area versus this area, depending on where the stroke is. But I don't think you guys have to know that for your test, like the specific locations. These are just kind of like a generic, like know what these terms are. Let's see. Here's another one. A fun one is, let's see if I can pronounce this. Homonymous hemianopsia. I'm gonna spell that for you. So like the root is homo, which means same. Homonymous, and then hemianopsia. So basically what this is has to do with vision. Now, I'm going to draw these two squares and pretend that's like your two eyes, like your right eye and your left eye. So like if you were to cut your vision, like everything you see like in half, like if I'm only looking with my right eye, like everything on the left side is going to be the left side, and everything from the center over will be the right side. Like you are unable to see like on that half of your vision, but it's also the same on this side. So notice that like it's both on the left side for each eyeball. So if I'm looking like this, I can't see anything over here. So I wouldn't be able to see from here over with this eye or from here over with this eye. So like one of the things you do like with your nurse is like teach patients to scan like this when they look at something so they can make sure that they're seeing everything. Because like when you're just looking straight ahead, like I wouldn't be able to see you because you're over here, right? Because that would be this half of my vision and I can't see it. I can only see this side.
So you would turn.
Yeah, you teach the patients to like kind of like look around like this before like crossing the street, for example, so that they don't miss something in this part of their vision. Okay. Does that make sense? Yeah. And so, yeah, the key words here is like the homo, which means same, it's like the same side of both eyes. Let's see. And then the only other last nursey term is aphasia. I think probably heard of this one. Yeah. So aphasia is the inability to either speak or to understand words. So like it's really frustrating for some patients because like they know what they want to say, but they can't say it. Like there's two different types. There's expressive aphasia and receptive aphasia. So expressive is like they aren't able to express the words. So they know they can understand you, but they can't talk. Like the connection between their brain and their tongue just it's not working. So a lot of times they're still able to like write or point, but they just can't talk. And that's usually from the Broca's area in the brain. Broca's area has to do with like the speaking. And then there's the receptive aphasia, whereas they just have no idea what you're saying. But like they can still talk, which is really interesting. Like they can say words. Usually it doesn't really make a lot of sense, but they're still able to like form words and make sounds. But they have no idea what you're talking about. They just have no concept. And that's the receptive aphasia. So it's easier to work with someone with the expressive because they can still like, they understand what you're saying and they can kind of figure out a way to communicate back with you, but they just can't talk physically, if that makes sense. Yeah. Was there anything else on here that before you walked in that you didn't get? I said usually the signs and symptoms are usually unilateral, meaning on one side. So if you have a stroke on the right side of your brain, it's going to cross over to the left side. So if you have left facial droop or a left arm weakness, it's going to be a right-sided stroke, and the same thing is true for the opposite. So
what is BBL?
Oh, this is blurred or double vision. Oh, double vision. So that's also called diplopia. If you see diplopia, that's double vision. Okay. And then hemiplegia is paralysis on the one side, and hemiparesis is weakness on the one side. So I might have just arm weakness versus paralysis, but they both have hemi because it's like hemisphere, you know, the one half. Yeah. So hemiplegia, paralysis, hemiparesis is the weakness. Okay. Does that all make sense? Yes. Okay. So those are signs and symptoms. If it's a transient ischemic attack, like one of those temporary strokes, the signs and symptoms will go away within 24 hours. And that's a warning sign. They're like, hey, you're probably like should go get checked out because you might probably be developing lots of plaque or atherosclerosis, which blocks the blood vessels, the blood to the brain. So that warning sign, be like, hey, maybe you need to go get surgery and have some of this plaque removed, right? But the good thing is that transient, the TIAs aren't permanent, so the side effects go away. Whereas a full-blown stroke, these are not going away unless you have like really, really good physical therapy. And sometimes you can gain back some of the weakness or whatever and build new pathways, but sometimes it can just be really difficult. Okay, so next thing we'll talk about is kind of some special signs and symptoms that have to do with if you're having a hemorrhagic stroke. So before you walked in, I was talking about the ischemic stroke is either from plaque buildup, like atherosclerosis, like from cholesterol and diet, or the plaque buildup around the arteries, or from a clot, right? Like you threw a DVT, or like, if someone has AFib and they throw a clot. And obviously, if you have a clot, those signs and symptoms are going to come on really fast because that just can happen in a moment, right? Whereas plaque and atherosclerosis, that's kind of like slow. You don't like develop plaque overnight and have a stroke the next day. So like those symptoms are going to kind of come on slowly versus this one can happen really fast. Now with hemorrhagic stroke, you're going to have some kind of unique signs and symptoms that you wouldn't have if it was ischemic, right? So all of these kind of apply to all strokes. Like even if you have a hemorrhagic stroke, you're still going to have these like as a result, right? Because you still have brain damage, right? But like during the active, like in like the current like acute stroke phase, you're going to have certain signs and symptoms that can be like, I'm betting they're having a hemorrhagic stroke, not an ischemic stroke, because they have certain ones that are different. So some of the unique ones, let's see, move this way a little bit. So the unique signs and symptoms for hemorrhagic that you won't see in ischemic is like really, really bad, severe headache. Okay, so like this isn't just, oh, my head hurts, but it's like the worst headache you ever had in your life, which makes sense because something burst, like a vessel in your brain just kind of bursted. Yeah, that's not really correct grammar, bursted. But so you would imagine that would hurt, right? So like you can either have really severe hypertension that causes a rupture, you can have an aneurysm, a subarachnoid hemorrhage, which is a brain bleed, or an AVM, which is an arteriovenous malformation, basically where the arteries meet the veins. They're just not lined up right, and it's just like a mess of vessels that are just like deformed. Yeah, like a big clump ball, and they're just not going right, and they're just really susceptible to rupture because they're really fragile because they're just not formed correctly. And those are kind of like, no one really knows exactly why people get them. Part of it's genetic. Women are more at risk for some reason than men are to have AVM. It's just kind of one of those things. So anyways, yeah, so you still have severe headache. That's like the worst headache you've ever had. You're not going to have that with ischemic, right? So that's different. Another one is going to be signs and symptoms of meningitis. So like that one's like kind of like, okay, that's weird, right? Especially specifically with subarachnoid hemorrhage. For whatever reason, like the bleeding in that part of the brain is just really irritating to the brain and causes a lot of signs of meningitis. Can you think of any that you know of, any signs and symptoms that like are for meningitis?
Nuchal rigidity? Yeah,
nuchal rigidity for sure, like the neck stiffness. So whatever it is about meningitis and hemorrhagic strokes, it does the same thing. So how do you know? Well, let me keep going. What are some other
would it be like infection signs, fever?
Well, it wouldn't, okay, not the infectious symptoms because you're not actually having an infection, but just some of the, like you said, the nuchal rigidity is specific to like meningitis. The other ones, can you think of like any of the signs? One starts with K. Kernig sign, do you remember that? No? Okay, so Kernig sign, this one is specific for meningitis. Basically, how I remember it is it sounds, do you know what Kermit the Frog is? So the little, I think one of the professors has like an obsession with an obsession with the Kermit the Frog. Basically, when I think of like Kermit the Frog, I think of like the frog legs that are always bent like this. With the Kernig sign is that the patient has like the inability to straighten their legs out, and they like kind of like sit with their legs bent like this. And like it's just they're just when the doctor tries to straighten their legs out, they can't because of like they have severe hamstring tightness, so they can't straighten it. So they just kind of like it buckles and they just kind of sit. Facing the frog legs, basically. So frog legs, it brings with the Kernig sign. That's specific to meningitis, but also to like hemorrhagic, specifically SAH stroke. So you won't see these with ischemic. The other one that goes along with it. Koenig is also Brudzinski's.
Oh, yes.
You've heard of that one?
We talked a little bit about
You talked about it in class. So this one is similar to the Koenig sign. The Brudzinski's one is like when they put their head to their chest, right? It causes their knees to buckle, right? So it's kind of the same thing with the knee thing.
Yeah.
But like when they take their head and put it like this, their knees kind of shoot up. So both of those kind of the same. So if you see those, you think meningitis, but again, you're like, okay, if you have a patient come in and they have the nuchal rigidity and the Koenig sign, the Brudzinski sign, how do you know if they're having meningitis or a hemorrhagic stroke? You do some diagnostic tests, right? So talk about those before you walked in. But one of the biggest one is a CT scan. Right, the CT scan shows an imaging of the brain, and if they were to be having like a plaque or a clot or whatever, you could see it on the scan, right? Especially if they're having hemorrhagic, you can see, there's blood in their brain, right? If they have meningitis, they won't have that, right? You're like, okay, because their brain's not bleeding, you just have an infection, right? So then you would look at like white blood cell counts, fever, those types of things, like signs of infection, like you mentioned. Yeah. So they won't have signs of infection with the hemorrhagic, but just these weird ones. Yeah, does that make sense?
Yeah.
Let's see what else. Another sign and symptom that is possible, but not always, is a seizure. Now, even if a person has like no history of seizures, for some reason, something about like the blood being outside of the vessels and like irritating the brain tissue can kind of like activate the nerves in such a way that gives people seizures. I don't know if you ever watched Grey's Anatomy.
Yeah.
There's one of the episodes kind of early on in the show was there was this young girl who came in and she was having seizures and no one could figure out why. And they did a scan and they couldn't see anything wrong. But then like eventually, what's her name? The main chick. Meredith Grey. Yeah. She's like, what if she does have a brain bleed? And we just didn't see it on the scan. So they do another one, found out she had a subarachnoid hemorrhage, which was just enough that was very small. It didn't get picked up the first time, but then they saw it and they realized that's what was causing the seizures because the blood was irritating to the brain tissue. So I've always remembered that. I'm basically a doctor because I watch Grey's Anatomy. No, I'm not. Oh, you got your degree at Grey's Anatomy school. Cool. Yeah. But does that make sense?
Yeah.
So it doesn't mean that you're always going to have seizures, but seizure can be a possibility.
So how do you tell if they're just, you would have to do a CT scan. Right?
Yeah. So the whole point of like the show was that they did one and they didn't see it, but then they did it again from a different angle and then they saw it, right? So, so you scans are the best way to tell like if there's something going on like a stroke or if it's just some unknown reason for the seizure. And then the other one, which will make sense, is a loss of consciousness or unconsciousness, because yours are bleeding out and you just, you have to have blood flow to the brain. And it's no different than being like choked out, right? Like you're not really gonna, I guess you could, but like you're not going to like rapidly go unconscious if you have plaque,
Yeah.
But like if a vessel ruptures in your brain and like you can go unconscious, right? So these are kind of unique ones, if that makes sense. You with me so far?
Yeah.
Okay, I'm gonna go ahead and erase some of this stuff.
You haven't gone through diagnostics yet?
I did a little bit, but there really isn't too much to that. Basically the big one is the CT scan, which can see not only like if they're having a stroke, like whether it's ischemic or hemorrhagic, like you can see if there's like a clot, or you can see if there's like a lot of bleeding in the brain, but you can tell where it is if they need to have surgery to fix it, right? So, and the biggest thing with the CT scan is to not use contrast. Right, because like let's say, because if you're looking at someone, they're having a stroke, you don't know by looking at them if it's hemorrhagic or ischemic, right? Like I can't tell, like just by looking, if you have the same signs and symptoms, right? But if you use contrast and it turns out to be hemorrhagic, now you just put all this dye and it shows up as like this huge whiteout on the scan. So you just see all this dye everywhere because it's supposed to stay in the vessel, right? But if it's a ruptured vessel, then all the dye that was supposed to be in the blood vessel is now all over the brain. Now you can't see anything. And you have no idea where the bleed is coming from. Like you just see blood everywhere, but you don't know if like the rupture is here You know, that makes sense? So you don't use contrast if you don't know if it's hemorrhagic or ischemic. And that's definitely going to be a test question, I promise you. So, promise. The other thing I mentioned was you might want to do an EKG to see if there's any cardiac involvement, because like I said, with people with AFib, they're likely to throw clots, right? So you could be like, okay, is this coming from AFib that they're having a clot, right? Another thing you might want to do is test their blood sugars, even if they're not diabetic, right? Because hypoglycemia can look a lot like a stroke, right? You know, the dizziness, slurred speech, confusion, maybe even loss of consciousness when people go into a diabetic coma, especially since diabetes is a risk factor for stroke, right? So people who are diabetic are more likely to have strokes. So if you have a diabetic friend and it looks like they're having a stroke, maybe check their blood sugar first before you like think they're having a stroke, because maybe their blood sugar is 12 and you're like, okay, that's what this is. You know, you give them some sugar and then they're fine, right? So those are some of the ones you like kind of rule out what else is going on, because some, you know, like I said, hypoglycemia can mimic stroke-like symptoms. Was there anything else on your notes about diagnostics that I missed?
Coagulation studies, like.
Yeah, and it's just to see like what your clotting levels are, you know, to see if they're really high. Maybe, you know, they can be like, oh yeah, you had a DVT.
And then just a CBC, troponin.
Yeah, again, just to rule out like, is this a heart attack or like what's going on?
Yeah.
You know, so I mean, they're gonna take a bunch of labs whenever you go to the hospital anyway, but those are like some specifics, you know, the reason why you're looking for it.
Yeah.
Okay, let's see. What are we gonna talk about now? Let's do, along with some of those signs and symptoms, did they mention anything about cranial nerves in your notes?
Just a brief.
We'll talk about it briefly. So cranial nerves, CN. Some of the signs and symptoms can be tied to the specific cranial nerves, and obviously the cranial nerves are going to be affected because we're talking about the brain, right? Because damages the brain, it's going to damage the cranial nerves. So, you know, some of the like the diplopia or the facial droop or whatever are going to be tied to specific ones. So cranial nerve number 5, which is also called the trigeminal, you're going to see issues with chewing. So my grandma had a stroke and she had a real hard time like chewing her food after that. So we had to like give her like, you know, like applesauce and things that were soft because she couldn't like chew potato chips. You know what I mean?
Yeah.
Because she just didn't have that ability. Cranial nerve number 7, which is the facial one, probably can imagine would be facial paralysis, right? So like facial droop / paralysis. You know, like they're only able to smile on one side.
Yeah.
So that's from the cranial nerve number 7. Cranial nerve 9 and 10, which is the hypoglossal and the vagal nerve, give you problems with swallowing and gag reflex. I have a video that I made on YouTube, kind of like one of these, about the cranial nerves. That I could send it to you if that would be helpful.
Yeah.
And then cranial nerve number 12. What was that one called? I don't remember. Cranial nerve number 12 is issues with tongue movement. Hypoglossal? No, really? What was number 9?
9.
I thought 9 was hypoglossal. I could be wrong.
Okay. I think I'm wrong, but
I don't know. It's fine. It doesn't matter. So tongue movement is going to be an issue with 12, which you can imagine probably has to do with speaking, because you have to do a lot of time to speak. So I don't know if they're going to like specifically test you on this, but you know, maybe just being like semi-aware of it.
Yeah.
Because a lot of this ties into the signs and symptoms that we talked about, but just being able to tie it to the specific cranial nerves. Now, let's say someone's got, you know, this problem, swallowing and gag. What are we worried about with this patient? Yeah, exactly. So aspiration, exactly. Like my grandma, she would always give us a heart attack because like she can't swallow super well, she can't chew super well, so it's like, you know, she'll start choking, you gotta like pat her on the back and it's like, small bites, grandma, you know. But she's just like wants to eat. Anyways, so aspiration, and what can aspiration lead to if you were to inhale stuff into your lungs?
Pneumonia.
Yeah, pneumonia, or even ARDS. You remember ARDS from acute respiratory distress? So now some nursing interventions that we're going to talk about here in just a second are going to, one of the specific categories is going to be specifically to prevent aspiration pneumonia, because often these are involved in stroke, because I mean the brain's here and like your face is right here, so I mean like it's all like you're gonna have a lot of like facial side effects with stroke. So like aspiration is a huge one for people with stroke. So a lot of the nursing interventions are related to avoiding this from happening. So I'm gonna go ahead and list those. All right, so patient care interventions. Can you see this marker okay?
Yeah.
I'm trying to tell, like from the video, it's kind of hard because there's like a glare. Oh. And so that's part of the reason why I have the lights off, because with all the lights on, it's like you can't even see the board. Oh. Okay, so one of the biggest one, like we said, is preventing aspiration. So there's several things you can do to do that. Most of the time, if someone has a stroke and they're learning how to deal, or like, you know, if it's just, they just came out of a stroke in the hospital, they're going to be assigned to speech language pathology and a speech therapist. And a lot of the times the speech therapist is going to do a lot of these things, depending on what hospital you work at and whether they have one or not. But the first thing, you know, the nurses are going to do at the bedside is a bedside swallow. Do you know about that?
Yeah.
What do you know about it?
Yeah, I thought that we do a kind of a test, but usually speech therapists like do another more deep.
Yeah, nurses, I've seen a lot of nurses like I don't feel comfortable, like, you know, I don't want this person to choke on my watch, so they'll like ask speech to do it. But nurses can do a bedside swallow. And basically what you give them like a little teaspoon of water and ask them to swallow it, you know, and see if like they hack it up or if like, you know, they're able to do it just fine. And if there's any issue, then you're like, okay, no, you're NPO, right? Because like, you don't know how much of that went into their lungs. If it's just a tablespoon of water, it's not really gonna hurt them too much. But like you can do it like, okay, was that fine? Or did they like hack that up or like cough, you know what I mean?
Yeah.
So if there's any question, you can get a speech therapist to do and you can also have them like do a barium swallow. You know what a barium swallow is?
I just heard it in the hospital, but I haven't.
Yeah, so basically it's like, how to explain, like they have a way of like using imaging to watch you swallow, so they can see exactly like where it's going, like if it's going down the esophagus or the trachea, and they can like see it on the screen and like watch exactly where it's going, and that will determine like, okay, like they're fine, or they swallow okay, but we need to thicken their liquids. You know, like the thicket stuff you can add to like water to make it like honey thick or pudding thick, to make it so it's easier for them to swallow. Yeah. So barium swallow, I mentioned the thicket, so I'll write that down. Have you used that stuff before? It's like a white powder that you add to water, and like however many scoops, it depends on like how thick you need it to be. So the more scoops of powder you add, the thicker the water gets. And it's basically like it turns water into like Jello, and it's like, so it's really weird because like they're eating like still solid water. And it's really weird. And it doesn't have a taste because it's just water, but it's just strange. Anyways, another thing is like, you know, giving them things to swallow, like with applesauce, like their pills and things. It's just easier for them to not aspirate it. Another thing is another thing that nurses can do is like tell the patients to tuck their chin to their chest when they swallow. So like you take a glass of water and put your chin down. The reason being is that your trachea is here and then your esophagus is behind the trachea. So when you put your chin to your chest, it occludes the trachea and kind of stretches out and opens the esophagus. So like I can kind of draw, this is going to be awkward. This is someone's head.
Oh, I see it.
So if this is, let's say this is the trachea here, it's going to like kind of pinch it right there, and it's going to open up this esophagus behind it. So it's going to kind of put pressure like on the trachea, and it'd be easier for them to swallow down the esophagus instead. Does that make sense?
Yeah.
Where was I? Like I said, speech therapy. So I'm just gonna put SLP. And then, you know, they might have to be put on MPO or an NG tube or TPN if they're just like really not able to do anything by mouth, but they need nutrition, obviously. Also, raising the head of the bed, right? It's much easier to eat when you're sitting up versus like laying down. So basic things like that. But these are, you know, they have pages of interventions in the notes. So these are basically like trying to break it down with like under categories. So preventing aspiration, and then you can kind of use your like common sense to figure out what you would do to prevent that, right? So preventing aspiration. The next one is for communication. Can I go ahead and erase this?
Yeah.
Okay. Okay, so another one is with communication, because I mentioned sometimes patients will have aphasia or agnosia or whatever it is, where they have a hard time communicating. So communication interventions. So they might use like pictures, you know, like little flashcards, like, what are you feeling? Thirsty, you know, happy, whatever, and have you point. Or you give someone like something to write on, like a whiteboard, little whiteboard, and so they can write on it. Another one is like speaking very slowly instead of like speaking super fast, and then like giving very clear, simple commands like, okay, now please sit up, and then like wait, like don't like just kind of keep talking at them, like, you know, just like giving this whole waterfall of like speech, like give very simple things, because if they're having a hard time like processing what you're saying, it's easier to digest like one simple thing at a time. Does that make sense?
Yeah.
Yeah, I mean, that's pretty much it. Like finding different ways to communicate, you know, whether it be like through signs or like, you know, pictures or whatever it is, just being creative, things like that. That's pretty much, I mean, that you can think of different ways. And then the last one is bladder and bowel training. So a lot of sometimes patients will, just put bowel training. Sometimes they'll lose like ability over like their bowel and bladder, you know, like, because that's one of the cranial nerves is like dealing with that. So if they lose the ability to, it basically makes them incontinent, right? So trying to, and you can gain back some of your function like with physical therapy. Like if you develop a unilateral weakness on your arm, like you can learn, I mean, there is part of it that's salvageable, right? You're able to go to physical therapy and they're able to train your brain to use different pathways to be able to move again.
Yeah.
So some of the bowel training is like, okay, giving someone a routine. So like every day at the same time, like, okay, now it's time to try to poop, right? And so like their body starts getting into a more of a routine, getting them to try and go pee like every 2 hours or so, like the urinal, and like getting them to consciously think about, okay, now we're going to try to do this, right? Does that make sense? Kind of putting them into routine. And then with the bowel, especially, you know, you still have like the nerve endings. So like one of the things that they can do is teaching the patients, and this might be kind of like, oh, gross, but like it's just one of those things like digital stimulation, that the patients can digitally stimulate themselves kind of down there, and it helps them like their like the peristalsis to kick in, to like get that bowel flowing out. So digital stimulation, and that's just kind of a conversation you'll have to talk with them and be like, hey, like, this is something that you can do for yourself to help it be easier for you. Because we don't want them to develop like constipation and then like have like maybe a rupture in their intestine or whatever, because then they have a whole nother problem, right? Yeah. Another one is suppositories, right? So like if they're just unable to go, you know, you can get suppositories to help them go if they just have lost like all types of ability to just go. So anyways, routine, you know, encourage them to try different things to help them to have more control, so they're not having access over themselves and being embarrassed.
Yeah.
You know.
Stool softener.
Stool softener will keep it soft keep it from getting constipated, but it's not going to like make you go.
Yeah.
You know what I mean? Stool softeners. Yeah, stool softeners aren't supposed to make you go, but they're just supposed to like make it easier to go.
Okay.
That makes sense. So, but yeah, I mean, obviously we'll make it easier for them if they have, especially if they have a hard time with constipation normally.
Yeah.
But yeah, the suppositories are supposed to like make you go, right? Yeah. Any questions about that? Were there any more interventions on your notes? Because my notes are like slightly different than yours, because mine are from a different year, so each teacher kind of adds their own things.
She just said assistive devices for eating.
Oh yeah, so like if someone's got like, you know, weakness in their arm or their hand, so they'll make like special forks that you can use. Yeah, so like they'll have ones I've seen like where you actually like it straps onto your hand, like kind of like you slip your hand into like, so you actually don't have to like hold it. It kind of just like, it's a not like a glove, but like a little strap that goes around your hand. So like even if you go like this, you can still hold the fork. And then the fork, rather than being straight, like a normal fork, you know, it's like curved like this. So like, imagine this being curved this way towards my mouth. So all I have to do is like lift it. I don't have to turn my arm like this. Because normally when you eat, you have to bring the end to your mouth. That requires a lot more like fine motor movement than just being able to go like back and forth. Because if it's turned this way towards your mouth, facing me, like imagine it's bent like that, I can just go straight in. Does that make sense? So that makes it easier for them to feed themselves. They don't have to be completely dependent. All right, let's see what else.
I think we touched on the other ones that she talked about: bowel and bladder control, impaired communication.
Yeah, if there's anything I missed, just yell at me.
Okay.
Because I don't have specifically you guys' stuff. Yeah. Okay, so now we talked about like signs and symptoms, the difference between hemorrhagic and ischemic, you know, different things like that. Like, what are you gonna do about it? Like, if someone's actively having a stroke, like what kind of interventions can you have, like surgery-wise, right? So there's different types of surgeries you can do to help if someone's having a stroke acutely. So surgical interventions. And they all have like kind of like long names. So the first one is called a carotid, I always say this wrong, endarterectomy. Do you have that on your notes?
I have are you trying for hemorrhagic?
Huh?
For hemorrhagic stroke?
This one, no, this one is for, I'll show you, endarterectomy. Okay. So ectomy, you know what that means?
Remove.
Yeah, to remove, like a hysterectomy, to remove the uterus. Yeah, so they're removing the plaque, right? So what they do is, like, let's say this is your artery and you have like this big old plaque buildup right there, right? So what they'll do is they'll cut open the artery and like remove the plaque out and then like stitch it back up, right? So that's what the endarterectomy is. Yeah. So if someone has just really bad like plaque buildup and cholesterol and things like that, that's constricting the vessel, and like they'll either do that. Sometimes people, I mean, some people do stents. That's more for like heart attacks and things. I don't know what they do exactly for in the brain, but so that's one of the things they can do is a removal of the plaque. Another one is a craniotomy. You think you know what that is?
Where they, I thought that was when they remove a piece of the skull.
Yeah, so cranium, right? So they go through the skull, and this is where they go in to evacuate or to remove the clot as well. Yeah. So both of these have to do with like ischemic, so plaque and clot, right? So this one, like the reason being is like, let's say I have a clot building up in my head, that's going to increase my intracranial pressure. I don't know if you remember that from the previous the lecture about increased ICP. I did an ASAP on that too. You saw it? Okay. So the intracranial pressure is a problem, right? Because your skull can't expand, so like it can cause serious damage. So they go in, we take out the clot to prevent an increase in ICP. So that's pretty straightforward. You just go to the skull. I don't really know if there's anything else about that they want you to know except for just what it is. They have this, I forget what they call it, but fancy term, but they basically have like this clot extractor, like wire that can go in with like little hooks. Yeah. And it's basically a catheter that goes up your femoral artery, like through your leg, and they grab the clot with the coils. Yeah. I don't know how to draw that, but like they have like these coils that go into the vessel, and it like grabs the clot and it's able to pull it out. I forget what it's called. Does it say in your notes?
No.
I just call it the clot extractor. But yeah, this one needs to be done according to my notes. I don't know if the standards have changed, but like within 8 hours of symptoms. Otherwise, it's just not really effective. So now some of the things, if you're having an aneurysm, and this one is, you know, for the hemorrhagic, there's different types of aneurysms you can have. So, and an aneurysm is just a bulging or weakening of the vessel wall that it's likely to rupture, right? So this is your artery, right? A berry aneurysm literally looks like you have a little bit of a blueberry just pouching out. So this is literally called berry, and I like that because that's easy to remember. It just looks like they got a little blueberry sticking out. So if they have something like this, what they'll usually do is they'll come and clip it. So not like cut it off, but like they'll take like kind of like a staple or like to pinch it off.
Yeah.
So they'll pinch it off with some kind of like piece of, I don't know, piece of metal or something to clip it so that it blocks blood from going in here and continuing to fill it up. So if it were to rupture, you know, well, it doesn't matter because the blood's restricted to stay inside, right? Okay. So that's a berry clip. And eventually this part will just die off because it's blocked the blood flow, and it'll eventually just kind of die, and like the body will heal over it. On the floor. Does that make sense?
Yeah.
So that's a berry. Then they have one that's called a fusiform. So here's your vessel, and it kind of just has a bulge in the middle, like all the way around. So it's just kind of like it's just swollen in the middle. So what they'll do with this one is they'll wrap it to reinforce it. So like they'll take some kind of, I don't know, wrap material and like wrap it all the way around to stabilize it to keep it from rupturing.
Yeah.
Does that make sense? To kind of reinforce it and kind of like an ace bandage for your arteries. Does that make sense? And then the last one, let's say you have kind of like this, you know, so it's not quite a berry because it's not like skinny at the end. It's not, you can't just clip that, right? Because it's too wide, but it's also not all the way around either. They can use something called like Guglielmi coils. I don't know if I said that right, but something like that. Basically, they put a little catheter in and they inject the area with like these coils to kind of block it off from preventing it to grow bigger. And then your body will naturally, because our body likes to clot on areas that are like not naturally part of your body, which is why prosthetic valves, if you have prosthetic valves in your heart, you're more at risk for developing clots. Because for some reason, like if there's like a synthetic object in your body, like platelets and things tend to stick to it. Yeah. For whatever reason. And so they want that, right? They want the platelets to stick to it and kind of block it off, right? So then it'll keep the blood flowing here without continuing to burst out. So that is like I said, the prosthetic, anything synthetic in your body is an increased risk for clots. So I think I mentioned prosthetic valves, one of the risk factors.
Yeah. I think she did mention that one with the from the femoral artery.
This one?
Intra-arterial adiplex or the stent retrievers.
Perfect. Stent retrievers, clot extractor, you know, whatever it is. Yeah. So this is pretty straightforward. I don't know if there's anything else specifically you had to know about them besides just what they are.
Just the care after that one that goes to the femoral.
What specifically do you know?
Just like puncture site assessment, leg straight 4 to 6 hours. Yeah,
so like if they're going in through the, you know, the entry site is in the femoral and they're going all the way up, you know, it's a long trip. Just, you know, keeping, you know, monitoring that site and then make sure it's not like bleeding out, to make sure it's, you know, keeping pressure, that it's not still bleeding, you know, keeping it still so they don't like rupture it and start bleeding because it's through an artery, right? So like if that ruptures, you could bleed out and die pretty fast. So I mean, just basically like letting it heal, checking it every so often to make sure there's not like, oh, we started with this much blood and now 10 seconds later there's this much blood. You know what I mean? So it's just kind of common sense, like, hey, be still, let it heal, check if it's bleeding out. Let's see. You know, then monitoring for symptoms of bleeding out. So like blood pressure, neuro changes. Like if they suddenly go unconscious, they're probably, you know, bleeding out. If their blood pressure tanks, they're probably bleeding out. So it's just common, you know, vital sign changes that you would expect, if that makes sense. Let's see. The last one is just different types of drugs. Now, I don't know how they organized it in your notes, if they kind of like mentioned drugs throughout the whole thing. I just kind of like to talk about them all at once because it makes more sense to me that way. So let's talk about all the drugs. Let's see if I can use the black one. I don't think the green one is showing very well. Okay, so the first one is going to be like anticoagulants. And this is like something you're going to want to be on, you know, especially if you have a high risk for stroke, or if you've had a stroke, or if you have AFib or something, you're going to want to be on like anticoagulants to kind of prevent stuff, you know. So Especially like, and even if they're having like an acute stroke right now, like, it's caused by a clot, you can give them like IV, right, and help kind of dissolve it right now. Does that make sense? So there's prevention anticoagulants, and there's also like, hey, you're having one right now, let's try and break it up. So IV heparin is an example of that. Now, do you know what lab value you check when you give heparin?
I always did the PT.
I know, I always get that wrong. Yeah. It's PTT.
Okay.
So eventually what helps me to remember, and this is kind of just like something kind of weird that like it doesn't always help everyone. But so how can I explain? PTT to me, like if you put two T's next to each other, kind of looks like an H.
Yeah. Yeah.
For heparin.
Okay.
Does that make sense?
Yeah.
I mean, I know that's weird, but to me, I'm like, two T's is an H. Heparin.
I'm like, is it PT or PTT?
Yeah, I always forget it too. So this looks like an H to me. So anyways, yeah, you're going to check the PTT to see, the therapeutic goal. So normal PTT is 25 to 35. Is that what yours say?
Yeah.
Okay. So that's what a normal person's PTT would be, like mine. If you're on, anticoagulant, you want it to be higher, right? Because this is the amount of seconds it's taking for you to like coagulate. So if you want anticoagulation, you want it to take longer to coagulate, right? So you want the numbers to be higher when they're on heparin or something. So you want it to be about 1.5 to 2.5 times the normal. So you want it to be like, to know that it's working, that you're in a therapeutic range, would be like somewhere like in the 60-ish, 75-ish range, about double, Is that what you're saying?
She didn't say that, but I'm sure.
Okay.
Yeah.
Well, this was in my notes. You want it to be about double, ish, to know that, okay, that the therapy is working. Does that make sense? Yeah. And then do you know, like, we gave them way too much heparin. What are we gonna do? What's the antidote? Yeah. So I hate these markers. They just are dying. So antidote is the protamine sulfate, like you said. So yeah, I don't know if you've ever seen a patient like on a heparin drip.
Yeah.
And you have to you take PTT and then you see the result and you either titrate it up or down in order to keep it within a therapeutic range. Yeah. So protamine sulfate, if they're like really high and like bleeding out, like I need to stop this right now. Need that. Okay, so now another drug you can give is Coumadin.
And for the heparin, she just said watch out for hits potential.
Oh yeah, okay. Well, that's always heparin-induced thrombocytopenia. I've never actually seen anybody ever have that, which is good, but that's not specific to like this topic of stroke, but just like anytime you give heparin, watch out for heparin-induced thrombocytopenia. Okay, so Coumadin is another anticoagulant, and what's the lab to test this one?
PT and iron.
Yeah. So mostly mine emphasize the INR over the PT. I don't know, I guess it's more relevant to this, I'm not sure. So the INR goal is to be about 2 to 3 while you're on the Coumadin. And what's the antidote for this one?
Vitamin K.
Vitamin K, good. Good, you can still see it. Okay, so those are the anticoagulants. We can do the antiplatelets next. Just a different classification. Antiplatelet. This way. Okay. Sorry, I have like my back to you now. Some antiplatelets, aspirin. Oh, gross, these markers. Aspirin, I'm just going to put ASA and Plavix. Do you have those in your notes?
Yes.
So they also had in my notes, now I don't know if this has changed over the years, but like not a good idea to mix them two together. Is that in yours?
Yeah, don't mix.
Don't mix, yeah, don't mix them together. And then, so that's it for antiplatelets. I don't know if there's anything else I want you to know about that. And then the other one is thrombolytics. So this one will like literally break up a thrombus. And a thrombus is a clot, right? Thrombolytic. lytic. Oh, I hate this marker. I need them to buy some new ones. Okay, so this one will literally dissolve the clot, right?
Yeah.
And this is the one where you have to like meet a certain criteria. So the one that probably have in your notes that everyone thinks of is TPA.
Yeah.
Thrombolytic plasminogen activator, something like that.
Yeah.
Also called activase, right?
Yeah. Yeah. Activate.
Whenever you see ACE, you can think of like to get rid of, like erase. So it's getting rid of the clot. So there's certain criteria you have to have in order to qualify to receive TPA, right? You have to have received it within 3 hours of the signs and symptoms onset. So like you can't come into the emergency room and be like, oh, I've had facial droop for 8 hours. Can I have activase? And they're like, no, right? It's not like 3 hours of when you got to the hospital. It's 3 hours of when you reported the signs and symptoms, right? So if you wait 2 hours before coming to the hospital, you have only an hour left, right? Patients might lie. I don't know. Like, oh yeah, I just started, you know. This can only be for what type of stroke? Remember there's two types?
Ischemic.
Yeah, you can only give this with ischemic because that has to do with the clot, right? If they're having hemorrhagic stroke, they're bleeding out. Obviously, we want them to clot. We want them to stop bleeding, right? If you were to give this with a hemorrhagic stroke, they're going to bleed out and they're going to die. Like that's literally it, right?
Yeah.
Does that make sense?
Do you also get heparin included with the hemorrhagic?
No, like, you know, these are specifically if it's the clot problem. Yeah. But this one just has a specific criteria, you know. Yeah, so we don't want to give this for hemorrhagic because they're already bleeding out. Yeah. We don't want to break up any clots that they have. We want them to make some, right? Was there anything else that was a requirement for in your notes about the criteria for having to have this? I know there's some contraindications.
Yeah.
Some contraindications mean like you can't, like if you have these things, you can't get the TPA. So mine says if you're over age 80, no TPA for you. If you're on oral anticoagulants like already, well, let's say you're at home and you're, you know, at risk for stroke, so you've been taking these like at home, they can't give you this on top of it. And then they can't give it to you if you have a history of ischemic stroke and diabetes. I'm not really sure why that is, but that's just on here. Another one says active internal bleeding, even if it's not the hemorrhagic stroke, like let's say you're bleeding out from another reason, which makes sense because that would also kill you, right? Severe uncontrolled hypertension, and you can imagine why. If you have really, really bad hypertension, that could cause an aneurysm, and then you get the TPA, and then now you have a hemorrhagic stroke that's not going to clot. Right, so like you have to get this person's blood pressure under control before you give them the TPA. Does that make sense? Yeah. I don't think there's anything else on there. Was there anything I missed on yours?
Not that you didn't mention.
And then the last thing specifically I had for drugs was something called triple H therapy. I think yours is called, what was it? Uvolete, something about volume. It says formerly known as triple H therapy.
I don't see it.
I saw it on one of the PowerPoints. It has like a picture of like several vials of water. I think it's towards the end. I was looking at E-class and I saw that one slide.
Yeah, I think that's how
you see it.
Yeah.
Yeah. What does it say? It says formerly known as triple H.
Yeah. It's the very last slide.
Yeah. What's it called? Does it have a name?
It doesn't have a name. It just says hemodynamic augmentation.
Yeah. Okay. Yeah. So I don't know if they just don't call it this anymore, but I've always called it triple H therapy, just because it has 3 H's and it's easy to remember. And none of these markers work. Oh. Okay. Maybe the pink one. Triple H therapy. Okay, so basically what the purpose of this is if someone's having a stroke, whether it be ischemic or hemorrhagic, like we know the problem is that they're having decreased perfusion to the brain, right? Whether because they're bleeding out or they're just not getting the blood. So this is in an effort to increase cerebral perfusion, right? So that's the whole point of this, increased perfusion. You with me so far?
Yeah.
Okay, so the first thing is they call it hypertension, but just so you can easily remember it. Like you don't obviously want to have uncontrolled super high hypertension, like 290 over 112, you know what I mean? But you want to have higher blood pressure in a neuro case than you do with a cardiac case. And I mentioned that in my other ASAP, if you remember. If someone having a heart issue, you want to give their heart a break by decreasing their blood pressure. But if they're a neuro case, you already have to pump against gravity, you know, because like going up is already harder. So you want the blood pressure to be a little bit higher so you can get that blood into the brain. So that's why I call it hypertension, but don't think like, I thought we didn't want them to have hypertension because they'll have a stroke. Like not super high, just higher than normal, right? So you can give, if someone has like low blood pressure, like, I don't know, 90 over 50, we want it to be more like 160 of systolic, like higher than normal, but not scary high. That makes sense? So we can give them vasopressors, you know, to help increase their blood pressure. And some of those can be epinephrine, norepinephrine, and dopamine. Those are some things to kind of increase that pressure so they can get the blood flow to the brain. The other one, they call it hypervolemia. And again, this is just to make it convenient to remember the H's, not that we want them to be fluid overloaded. But you want to give them fluids, right? Because if they have fluids, they're going to have more flow to the brain, right? So you're going to give them like IV fluids, like for example, something like normal saline at 150, right? And then the last one, I mean, this isn't really, this kind of goes along with everything we already talked about, but the goal is hemodilution. Basically what that means is that you want to kind of like dilute the blood and make it less viscous. Do you know what viscous means?
Like, no.
Yeah, like thick. So like pudding is more viscous than water, right? Like you can measure viscosity by like if you were to pour it, like you pour water out, it comes right out. You try to pour pudding, it's gonna like take a minute, you know what I mean? So with blood, we want it to be less viscous if they're having a stroke, so that we can like get that, because we don't want clunky blood trying to like slowly get up there. And we want to like have really thin blood so it really gets up there and perfuses really well and doesn't take forever. So again, most of that is accomplished by what we already mentioned already, but and you want to try and keep the hematocrit because that's how you measure like the concentration. Like you said, you want the hematocrit to be less than 30. So that's the goal, to accomplish hemodilution. Does that make sense?
Yeah.
I guess I could have just called this one hematocrit, less than 30 instead of hemodilution. But so those are the goals: increase the blood pressure, you know, give them more fluids in order to accomplish hemodilution. So, all right.
Other meds she mentioned was lipid lowering medication.
Oh yeah. Okay. So those are more like kind of like maintenance, like at home. Like if you've had, like especially if you've had ischemic stroke, like if you had a plaque buildup, or you know, due to cholesterol and diet or like whatever, you can be put on a statin like Lipitor, rosuvastatin, all those different things, which are going to help reduce your cholesterol, right? So you can reduce the plaque. So that's not really like an emergency medication. That's more like a maintenance, like at home, you need to be put on this. And some of the other ones are like blood pressure medicines, like maintenance blood pressure medicines if the reason for your stroke was because you just have high uncontrollable blood pressure. So you're kind of just treating whatever it was that caused the stroke. So it's like, okay, why did you have your stroke? Did you have your stroke because your diet is terrible, then you use statin? Or did you have it because your vessel bursted, because you have hypertension, you need blood pressure meds? Does that make sense?
Yeah.
Was there anything else?
You talked about platelet inhibitors, right? Yeah.
Aspirin and Plavix. Yeah.
Anticoagulants. Yeah, those are it. And then just nursing care for the TPAs.
What does it say on there?
Neural assessment, blood pressure.
Yeah, I mean just normal vital signs.
No aspirin.
Yeah, look for aspiration. Always check for nerve changes.
Yeah.
Measure their blood pressure, heart rate, like stuff that you would do with anything. So it's nothing really like unique, I guess.
Yeah. How is that?
The stroke's not too bad. I mean, there's stuff you have to learn, but it's not like, oh, my brain hurts trying to understand this. You know, like some of the cardiac stuff, like with the rhythms and things, I was like, oh my gosh, like I have to wrap my mind around it. But I feel like this kind of stuff isn't too bad. Yeah. Do you have any specific questions? Anything I missed that you're not clear on? Maybe from the beginning that I didn't cover?
You know more about vasospasms?
Vasospasm? Oh, did I not mention those?
Maybe you did in the beginning.
Oh, I did. I had it down here at the end. I missed it. Okay, so vasospasms. A spasm, you know, just kind of like it's just spasming for whatever reason. Just the spasm is basically like the vessels constricting for no reason. So like you'll have your normal artery, and then it'll kind of just all of a sudden like spasm and constrict, which reduces the blood flow, right?
Yeah.
And so like you're gonna have similar like neuro changes because you're having, but it's not a stroke, right? You're not having there's no hemorrhaging and there's no clot, right? So sometimes this happens like after someone's had like a hemorrhagic stroke and they still have like residual blood kind of irritating the area, if that makes sense. So like, let's say this is just some blood that's left over from the brain bleed. It can irritate the area and cause vasospasms. So one of the things that they can give you drug-wise, that I just forgot, I have it right here, is calcium channel blockers. So CA channel blockers, specifically like, what's it called? Nimodipine. Will help to prevent the spasms from occurring, right? Because this will present similar to a stroke, right? Because you'll have the same narrowing of the blood and decreased perfusion. Yeah, it's just one of those weird things that like sometimes that blood can irritate the area when it's not in the right place.
Yeah.
Same thing with like the seizures. It's just one of those things.
Yeah.
Was there anything else in there about it?
Just with the to just assess people after I guess you take care of the stroke for rebleeds, hydrocephalus, vasospasm.
Yeah, I mean pretty much the assessments are going to be the same for all of them. Like assess neuro changes, assess blood pressure, like all the things that you would look for pretty much going to be the same for each thing.
Yeah.
So any change, you call the doctor.
Yeah.
Like, hey, they're having something weird, come fix it. That's basically the answer. Hope that helped.
Thank you so much.
Let me just pause on this real quick.
Yeah, you went through all of it.